Welcome, everyone, to the University of New Mexico Law and Mental Health series, weekly discussions of practice and science featuring experts in behavioral health and the law. This is a series run by the University of New Mexico's Division of Forensic Behavioral Sciences in our Department of Psychiatry and Behavioral Sciences, along with support of the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenters, you can enter those in the Q&A box anytime that you feel comfortable. Do know that we hold questions until the end, and oftentimes it's not possible for us to get through all of them. In terms of continuing education credits, if you are pursuing continuing medical education credits, there is a link in the chat box now that you can complete and sign in to receive those credits. For those of you that are pursuing APA continuing education credits, there will be a link to a survey that you will complete. It will be posted in the chat box, but near the end of the webinar. So you'll keep your eye on that chat box as we get closer to the top of the hour. Make sure that you open, bookmark, save that link before the webinar closes, and then make sure that you save a version of the certificate after you complete the survey. We don't have certificates of our own after the fact. If you missed our most recent talk in the series, Dr. Randy Otto's discussion of principles of forensic report writing is now available on our YouTube channel. The recording for this week's talk should also be available on our YouTube channel sometime later this week, and a version of the PowerPoint slides for those that have registered for the series will be available later this week as well. As a heads up, next week we have Dr. Talia Armstrong, who'll be discussing artificial intelligence issues in forensic psychology research. But circling back to this week, I'm honored to introduce you to today's speakers who'll be discussing issues of aging and cognition relevant to forensic evaluation. Today we have Drs. Lisa Kahn, Chriscelyn Tussey, and Beth Arredondo. Dr. Lisa Kahn is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Texas Health at Houston. She earned her doctorate in clinical psychology from Sam Houston State University and is a licensed psychologist in Texas and Virginia. She's worked with justice-involved individuals in both research and clinical contexts across various settings and jurisdictions, and her clinical research interests include individual and systemic influences in forensic mental health assessment, psychological testing in forensic mental health assessments, as well as application of psychological science in the legal system. Dr. Chriscelyn Tussey is the president and founder of Metropolitan Forensic and Neuropsychological Consultation in New York City. She's a clinical neuropsychologist and board-certified forensic psychologist who conducts clinical as well as civil and criminal forensic and forensic neuropsychological evaluations. Dr. Tussey is a clinical instructor at NYU Grossman School of Medicine and an adjunct professor in the graduate psychology programs at NYU and Columbia University. She's currently on the board of directors as the secretary for the American Academy of Forensic Psychology, is a fellow of the National Academy of Neuropsychology, and a member of the Leadership Ambassador Development Program. She's also honored to serve on the editorial team for the updated Oxford University Press book series, Best Practices in Forensic Mental Health Assessment. We also have Dr. Beth Arredondo. Dr. Beth Arredondo is a board-certified clinical neuropsychologist at Ochsner Health in Covington, Louisiana. She completed her PhD in clinical psychology at Sam Houston State University and then a general internship and postdoctoral fellowship in clinical neuropsychology at the University of Massachusetts Medical School. She joined the Ochsner team in 2017 and is actively engaged in clinical work, forensic work, and research. Dr. Arredondo co-directs the Clinical Neuropsychology Postdoctoral Fellowship at Ochsner and is actively involved in professional service with service positions in national neuropsychology and forensic psychology organizations. So Drs. Kahn, Dr. Tussey, Dr. Arredondo, on behalf of the University of New Mexico, thank you so much for joining our series, and we look forward to you sharing your expertise with us today. I'll go ahead and toss it over to you.
Thank you so much, Anthony. Can everybody see my slides okay?
Yes, it looks good.
All right. So thank you, Anthony, again for the invitation and warm welcome. My name is Lisa Kahn, and as Anthony said, my colleagues and I are here to talk about older adults in the criminal justice system. Alex is helping us today, and he'll be launching a poll with one question for you to answer, and this will be up for about a minute or so. Going through, Anthony already talked about the process on receiving your CEs, and we have no disclosures to reports. And just to be clear, the views expressed in this presentation are ours only and do not necessarily represent the views, policies, and positions of the University of New Mexico. So our learning objectives for today, we want to emphasize that this is a brief overview of a broad topic, and we won't be able to cover all aspects of older adults in the criminal justice system, including their time in jail. but we will be discussing the changing demographics in the criminal justice populations, talk about diagnostic and pragmatic factors relevant to pre-trial and trial when evaluating aging defendants, and identify special considerations for release and reentry in the older adult population. So changing demographics and its impacts. So first, who is an older adult anyway? Typically, we think of older adults as individuals 65 years or older. This is consistent with the social benchmarks in our society, such as retirement age and eligibility for Medicare. This is also the age that NIH uses to define older adults. But for incarcerated individuals, we consider older adults who are 50 years or older, and this is in recognition of the social determinants of health and the negative impact of incarceration on the aging process. And depending on the source of data, you'll see different cutoff points. So you were asked how many older adults 50 plus did you assess for forensic purpose in the past 12 months, I'm sorry. Alex, can you share the results, please? So many of you have worked with older adults in the past year. Some of you haven't. If you haven't, you're probably going to start doing so simply because the aging of the US population system. So this is information from the census that shows, oh, I'm sorry, I don't know what happened. Give me 1 second. Okay, so this is information from the US Census, and it's two figures showing the number and percentage of people age 65 or over since 1920. As you can see, in 2020, about 1 in 6 people in the US were age 65 and over, compared to in the 1920, only about 1 in 20 were 65 and older. And multiple reasons have been given, including lower birth rates, better healthcare, and increased longevity. And we'll see similar trends in CJ populations at different stages of the legal process. So for arrest, and we're going to focus on the left side of the chart for now. This is an infographic from the Prison Policy Initiative, and it shows that older adults are accounting for a greater proportion of arrests, jumping from about 2% in 1991 to about 8% in 2021. We see similar trends in jail. So we actually have less information for jail populations. The Bureau of Justice Statistics, BJS, did not begin collecting counts by age groups for their annual survey until 2020. But as you can see, this is from the 2023 report, the 65 plus group has increased disproportionately at about 78% compared to just adults in general at 21%. Again, moving on to prison populations, we see similar trends. This is compiled from the BJS Prisoners Series, which report the data in percentages and not counts, hence the difference in how the data is being presented here. But you can see the steady increase in the proportions of older adults in prison populations. And if this trend continues, it is projected that the 50 plus groups will account for about 30% of the prison population by the year 2030. So what are the impacts of incarceration? This is a topic that Wiley and Branks addressed in one of their chapters on their book on aging in the criminal legal system that they published just last year. In terms of social support, older adults report trauma from being separated from their family and community. They tend to have fewer visits over time due to the aging of their support system in the community. There are high rates or high levels of fear about being victimized. And one of the study looked at both administrative data and self-report data. And they found that there are high rates of victimization, including threats, being cut in front while in line, being cheated out of money, and having their property stolen. incarcerated older adults also report higher levels of anxiety about death and dying than their community counterparts. This is related to fears of dying alone, dying without the opportunity for reconciliation, perceived lack of health care, and perceived lack of or perceived indifference from detention officers and peers. And these fears are not unfounded. Older adults accounting for a greater proportion of deaths in custody from about 34% in 2001 to about 63% in 2019. We already alluded to the detrimental effects on their physical and mental health. Studies have indicated that the health profiles of incarcerated older adults are more comparable to their community counterparts who are 10 to 15 years older. On average, incarcerated older adults have 3 chronic health conditions and are prescribed 7 to 10 medications. They have higher rates of depression and schizophrenia than their community counterparts, and they have the highest rates of suicide among inmate populations. And the Prison Policy Initiative estimates that each year in prison takes off 2 years off of life expectancy. And what about cognitive functioning? So in 2016, BJS asked about disability status in their annual survey of prison inmates, and about 23% of prisoners self-reported having cognitive disability. One of the more cited research from Miller and colleagues in 2023, they looked at the prevalence of Alzheimer's disease and related dementias based using data from their Department of Corrections and cross-referencing that with data from the Alzheimer's disease and related dementias registry for the states from 1992 to 2006. And what they found was that the prevalence ADRD is about 14% among state prisoners who are 55 years or older versus about 7% in the general population. And Wilson Barbosa estimated that the number of prisoners with dementia will double by 2030 and triple by 2050 based using prevalence rates in the general population. So, and to be clear, dementia is not part of normal aging, the normal aging process. And this is a slide from the UC Irvine Institute for Memory Impairments and Neurological Disorders that shows general trajectories of cognitive changes over time. Everyone will experience slight cognitive changes during aging. A group of them will develop will enter what they call the preclinical stage, and they call it the silent phase or stage where the patient knows, but where the doctor doesn't, because the changes are not yet detectable on tests. A subgroup of them will go on to develop mild cognitive impairments or MCI. The cognitive changes here are of concern to individual and their families, and there will be one or more cognitive domains that is significantly impaired. But usually their activities of daily living are preserved. Then a subset of those will go on to develop dementia, and this is where cognitive impairments are severe enough to interfere with everyday abilities. And individuals diagnosed with MCI or dementia, by definition, have more problems than expected for their age. And as you can see, not everyone who with diagnosed MCI will go on to develop dementia, but studies have shown that MCI is a risk factor for developing dementia later on. And a little more about normal versus abnormal aging. Older adults going through the normal aging process, they typically take longer to learn new things. They might have occasional bouts of forgetfulness. They might engage in poor decisions on occasion. Their processing speed might be slower, but their daily functioning is intact. For those diagnosed with MCI, they have more frequent bouts of forgetfulness. They may have more trouble with word finding, but their personality typically remains unchanged and their difficulties do not interfere with daily functioning. Versus those with dementia, these individuals are unable to remember important information. They have trouble having conversations and following directions. They may get lost in familiar settings. They might experience increased anxiety, agitation, disinterest, withdrawal, or paranoia. So, and this is just a brief overview. Dr. Tussey, Chriscelyn will go over that different forms of dementia later on, but this is a slide from University of Queensland in Australia. As you can see, Alzheimer's disease and vascular dementia are the most common types of dementia. And the common areas of impairment across the dementias include attention, processing speed, executive functioning. This includes reasoning, planning, and impulse control, memory, communication, and perceptions. And all these difficulties have a great impact on the cost of imprisoning older adults. One study estimated that incarcerating older adults costs 3 to 9 times higher than it does to incarcerate younger adults. And it's such a wide range because the a lot of it is due to healthcare costs. And now I'm gonna turn it over to Dr. Tussey, who will talk with you about cognition and FMHAs with older adults.
Thank you so much, Dr. Khan. Hopefully everyone can hear me okay. That was an excellent foundation about the differences in aging and why this matters for the forensic mental health evaluations that many of you have already done. Some of you have done 10 or more evaluations recently. And so it's important that we understand some of the aspects of cognition and how this is relevant. Today, as she mentioned, we really only have time to do a brief overview of factors to consider. And I'm going to discuss pretrial and trial considerations. Obviously, there's the whole aspect of what it's like when somebody's incarcerated and things to consider. But from the perspective of forensic mental health evaluations, many of us are doing competence to stand trial evaluations. And we know that in this case, cognition, particularly if there's question about dementia, can have significant consequences for restorability questions. And whether or not dementia was a factor in criminal responsibility type evaluations is a very important consideration as well. I would not say the majority of these types of referrals, obviously, are hinging on whether or not someone has dementia, nor do I want to imply that dementia is the only consideration in older adults that we need to make. But because of its prevalence, as Dr. Khan so nicely highlighted, it's important that we consider it substantially when we're working with older individuals. Same is true in mitigation and civil capacities, which we don't have time to get into today, but factors like guardianship, consent, testamentary capacity, these are all very increasingly common forensic mental health evaluations with this population. So what are some of the unique risks in older adults? Wiley and Brank in their new book, which is excellent, has summarized this very nicely. And it's also discussed in Shane Bush and Brian Yoakum's book from 2022. And again, some of these, like delirium misdiagnosed as dementia, depression mistaken for incapacity, we think of more commonly when we may think of older individuals, or sensory loss that manifests as cognitive impairment. And so issues such as not being able to see appropriately or needing hearing assistance and not having that, these can manifest in behaviors that look like dementia. If somebody cannot see or hear adequately, then that can lead them to social isolation, can lead them to being confused, can lead them to mishearing information, and then that can look like memory impairments. So whenever we're evaluating individuals that are older, especially in an carceral setting, it's very important to consider, do they have hearing aids if they need them? Do they have their glasses if they need them? What other sensory factors might impact how they're presenting? Psychiatric, the latter half of these, psychiatric and substance use, sleep, pain issues, fluctuating symptoms, obviously can be present across the entire lifespan. But I want to specify, as it relates to older individuals, factors like psychiatric and substance use disorders, especially if these have been chronic, unmedicated, or undermanaged or treated, these can have incrementally building impact on someone's cognitive functioning. And if you factor those issues in conjunction with a potential dementia, that is going to make those symptoms snowball much quicker. Sleep, fatigue, chronic fatigue, and pain issues are quite prevalent, increasingly prevalent with age. And this is especially true whenever we think about those that are incarcerated and may not be getting the type of care that they need to handle these issues, which may seem secondary to, some of the other priorities of the criminal justice system. And fluctuating symptoms. This can be confusing because when we're evaluating older people, perhaps they seem lucid and clear and articulate in one meeting, and then we see them later, a few weeks later, even just a few days later, and they're not like that any longer. And sometimes it makes clinicians wonder, what's going on from a diagnostic perspective? Are they exaggerating? It's not uncommon that individuals in the correctional setting may view this as feigning or exaggerating symptoms because perhaps they're incoherent when you meet with them, but an officer would say, well, they spoke to me and they were very clear and knew exactly what they wanted and instrumental in their conversation just a few days ago. That doesn't necessarily mean that there is not an issue at hand. And we've spent a lot of time thus far talking, just kind of scraping the surface of dementia, and I'm going to talk more about it. But it is very important that I bring up the issue of delirium. Now, many of you are familiar with delirium. It is very different than dementia in terms of some of its symptoms. However, there are some overlapping symptoms that we're going to talk about in a minute, but it's a necessity to consider when you're evaluating somebody that's an older individual and they have a change in mental status or they're acting differently from a cognitive perspective or behavioral perspective than you would have expected. So, what are some of the causes of delirium? Some of you, or maybe all of you, are familiar with the fact that urinary tract infections, for example, in older individuals is one of the most primary and frequent causes of delirium. And the UTIs can present in individuals when they're older, and they may not even be immediately aware of those symptoms. Other issues such as dehydration, other types of infections, medical conditions, sepsis, for example, heart conditions, dementia as well can sometimes present as some of these symptoms, which I'm going to discuss. Lack of sleep, excessive emotional distress, surgery, having recently had a surgery or medical intervention. These are just some of the potential causes of delirium. And it's, as I'm going to discuss in a minute, it's essential to distinguish delirium from dementia because they have very different outcomes and possibilities for forensic mental health evaluation and even necessary interventions. As Dr. Kahn highlighted, there are numerous types of dementia. These are only some of them. And it's important if you're going to be working with an older population to be familiar with the different types of dementia. We most often hear about Alzheimer's and vascular. In the United States, combined type, particularly Alzheimer's and vascular, is extraordinarily prevalent. We don't always know that it's combined officially until autopsy. However, with the invention of biomarkers and in evolving science, we're going to get better. Particularly right now, we're getting better at examining Alzheimer's, but there's still a lot of work to do with diagnosing this. They all have different symptom presentations. And again, in the interest of time, I'm not going to go through each of these in depth, but I will say what we typically think of as society, when we think of dementia, I think the majority of people think about Alzheimer's disease, which is marked by word finding problems and perhaps getting lost or wandering around, repeating stories. But in reality, yes, that's a very prevalent form of dementia. But another one that I want to call your attention to is frontotemporal dementia. The onset of FTD is usually in the 40s, in the range of 40s to 60s, versus the onset of Alzheimer's, which we usually don't see occurring until around your 60s. And so with FTD, often as someone presents to you in their 40s, and they have symptoms such as a change in personality, perhaps new onset of impulsive behaviors or apathy, personality changes, we might consider other differentials, such as, are they abusing substances? Are they not taking their medication? Is there a neuroanatomical issue, a brain tumor? And all of those should be considered in the differentials. But we should also consider the possibility of frontotemporal dementia, which has different variants. One of those is the behavioral variant. And this particular variant in the research, we've seen that individuals with FTD tend to get introduced into the criminal justice system later in life than others. So, for example, they may be in their 40s or 50s and have an interaction or arrest for the very first time in their life around their 40s or 50s. And you're wondering, well, what could be going on with this individual? And I encourage you to consider other forms of dementia, such as FTD, even if the age doesn't align with what we're typically looking for. Because FTD, as the name implies, affects our frontal lobes and the part of our brain that's responsible for putting the brakes on behavior and motivation and changes in personality. And it has a very different course. And we don't often think about it again because it doesn't present first with memory problems, but we're seeing it at an increasing rate in the criminal justice system. So, as I mentioned, it's necessary that we are aware of the difference between delirium and dementia. And just to highlight a few examples of how they're different, we typically think of dementia as being a slow and gradual onset. This is true with the majority of the forms of dementia, whereas delirium is typically quick. It may be most obvious if someone's just had a surgery and you're noticing these symptoms. But again, in the case of a urinary tract infection, it is also tends to be quick with a definite beginning point. Delirium can last for days to weeks, whereas dementia is permanent. It's neurodegenerative, so we don't expect improvement. Delirium is usually reversible. And again, neurodegenerative disorders are not, they're progressive. Delirium tends to get much worse at night. That's true for dementia as well. You may have heard of the term sundowning, where people get more confused or more impaired at night. And cognitive factors such as attention tend to be greatly impaired, whereas in dementia, you may not notice a significant impairment in dementia until someone's more in the moderate to later stages. And consciousness. So typically our consciousness is not impaired in dementia, though it's variable whether it's impaired or not in delirium. And to be clear, of course, you can have dementia and delirium, but it's important to note the difference because, again, the treatment and the way we evaluate these individuals is very different. There are a lot of comorbid conditions with dementia. These are just some of them. You're aware of the mental health comorbidities, multimorbidities, some of these vascular risk factors and lifestyle factors. We also know that the social determinants of health, as we're going to be talking about throughout this presentation, are necessary to focus on when we're thinking about dementia and comorbidities. So factors like someone's access to healthcare, and we know there are many inequities there. How does that impact their ability to be assessed and their ability to be treated or at least have interventions to manage these symptoms? And we know that with dementia, there tends to be a decline over time, quality of life declines. Sometimes it's gradual, sometimes it's more step-like, for example, in a vascular form of dementia. But again, with delirium, we know that people tend to get better if the etiology of that is treated. Snowden and colleagues in 2017 looked at a systemic review of people with moderate to severe cognitive impairment, including dementia. And you can see that having these conditions substantially increases mortality, shortens survival times, and certainly increases length of stay in institutional settings, and such as nursing facilities, for instance, or hospitals. Miller and LeDuc in 2024 did an interesting study that's one of very few on this because, believe it or not, there's just not that much research on dementia and its impacts in the criminal justice system. There's an increasing body of it, but there's not as much as I wish that there were. And they looked at 118 legal decisions published between 2002 and 2022. And you can see in table 3 that the court accepted a multitude of these diagnoses. But what I think I really want to highlight is figure 3, the competency determination. This is related obviously to competence to stand trial. And individuals were deemed incompetent more often when the evaluator found a diagnosis of dementia NOS. Now, we know we don't have that language anymore in the DSM-5 TR, but an unspecified diagnosis. And a lot of times, forensic mental health evaluators or other clinicians give an unspecified diagnosis because we're just not clear about all the potential other etiologies. And in a carceral setting, you may not be able to get the thorough multidisciplinary workup that really is ideal to assess for dementia. But you can see here that diagnosis alone, as unspecified as it is, still accounted for the majority of the incompetent findings. So in short, there is a low restorability when someone has dementia. And that's why it's very important, again, to consider these factors when you're evaluating an older individual. And there are implications. Now, having dementia doesn't mean you cannot be restored, as we'll discuss in 1 second. But if you have delirium and or depression, which also can present like symptoms of dementia, but are reversible, there is a much greater ability to be restored. So in Morrison Parker, this is a bit of a dated article, but one of the best and only ones I can find since this day, they looked at individuals referred for competence restoration in Indiana to a hospital. Several of them had dementia, and 2.2% were 65 or older, but did not have a diagnosis of dementia. And they found that restoration rates were lower for both groups. But of those with dementia, still about 49% were restored to competence at 6 months, and then 36% by 1 year. So again, like much of what we know, for example, with competence, there's not one diagnosis that precludes that bar. However, it's important that we consider factors like dementia, but also other potential differentials such as delirium and comorbidities. So I want to switch now and just speak briefly about testing considerations. If you're doing an evaluation with an individual that's older, and especially if you're doing testing, we know that factors, even like in that picture a second ago, if somebody is shackled at the ankles, imagine if that older individual has mobility issues. That can cause substantial stress just going to the evaluation room, for example. But individuals that are older may have polypharmacy concerns. They may not be familiar with testing. They may have some of the sensory impairments I just mentioned to you. And so we adjust by providing some sort of accommodation. And again, I'm going to speak as if we're doing testing, but things like maybe modifying the instructions a little bit or changing the seating arrangements, providing enlarged text, ensuring that we have multiple testing sessions. And all of these can be useful, but we do also have to balance that with the validity of testing and whether or not it makes sense to do testing with that older individual in the context of any of these forensic mental health assessment referral questions. Some screeners that you're likely familiar with, but I want to call your attention to, are the MoCA, Montreal Cognitive Assessment, the RBANS, Repeatable Battery for the Assessment of Neuropsychological Status, the DRS, the Dementia Rating Scale. Now, I want to emphasize that these are screeners. They do not constitute comprehensive neuropsychological evaluations, nor are they sufficient to render a diagnosis of dementia. However, they can provide useful information about someone's functional abilities in a relatively short amount of time, and they're very commonly used with our older population to address a variety of forensic mental health questions. Also, there are performance validity tests that are typically used with this population. These are just a smattering, but we know that if we're going to do any sort of cognitive testing, whether it's in any population across the lifespan, we need to include measures that look at performance validity. So measures like the TOM, coin in the hand test, dot counting test. The RBANS has built-in measures, the effort index and effort scale. And you can see the TOM is the most validated PVT in an older population, but some of these others also have been used quite frequently. At the same time, we have to consider whether or not there are appropriate norms to use with these individuals, whether or not we need to consider the cutoff, just being careful when we're interpreting those test data within not just the population because they're older, but their cultural backgrounds, linguistic backgrounds, sensory difficulties, et cetera, that may impact their performance on testing. Then lastly, I'll wrap up with the importance of communicating about cognitive deficits in these individuals in trial. It's important, obviously, that we're very careful about how we communicate our results with any population. We don't want to overstate mitigation. And there are some individuals that have a bias that they want to help older individuals and sometimes a bias ageism in a negative way against older individuals. I think it's very it's very important that we are aware of that bias, and we know that being aware of our bias is not sufficient, but that we also proactively try to mitigate any biases we may have. And that can look like, oh, well, there's no way this person would have done this because they're older, or maybe they remind you of someone in your life that's older, or maybe, there's a bias in the opposite direction. So it's important that we proactively mitigate against those to avoid any sort of ethical dilemmas. And Karen Postal was a neuropsychologist who did some amazing work. And she unfortunately passed several years ago, but she has imparted so much knowledge with us. If you haven't seen her book on testimony that sticks, I highly recommend it. It's not just focused on older individuals, but some incredible information in there. And she said it's important that we turn raw numbers into a human story. And I encourage us to think about this as it relates again to anybody we're evaluating, but especially an older population. If you're going to testify about these results, what might that look like? And how can you explain test data that aren't going to be that interesting or clear to a layperson jury, for example, in a way that actually helps humanize the individual? I'll leave you with this. This is an excellent collaborative project between the American Bar Association and several organizations, including University of Virginia and University of Michigan. And because of the recognition that this is a fast-growing population where there's not a lot of research and there is a great need for policy changes, this was commissioned to put together some next steps for this particular group that we're going to continue working with increasingly as time goes on. So I encourage you to take a look at that. And I'll turn it over to Dr. Arredondo.
All right, thank you very much, Dr. Tussey. Can everybody hear me and see me okay? All right, wonderful. I have a gremlin in my microphone, so if it goes down, just sort of wave at me and I will fix the error. So thank you very much to Drs. Khan and Dr. Tussey for sort of setting the stage. And as they mentioned, even though the period of time when an older adult is incarcerated is incredibly important in an hour, we just had to pick and choose kind of which spots we wanted to highlight. And we thought that in terms of release and reentry, folks who are doing forensic work or working with older adults may have more opportunity if they're not already working in a correctional setting to kind of be involved either at the evaluation stage or in kind of helping with outreach, policy, advocacy, and so on. And so as you saw in Dr. Khan's slides, the growing percentage of the prison population and jail population that includes older adults, that is due to a lot of different factors, just the aging of the community in general, but also to some sentencing decisions that were made in the 80s and 90s, where a lot of people who went in as younger adults have lived, decades of their life within the prison system and are now either getting out because of sentencing reforms or because of opportunities for release. And so that's where we're going to focus, is sort of release from the jail or prison setting, not release from state hospital settings or other kind of community settings, although those issues are still relevant in those settings as well. Here we go, let's make sure. All right, so when somebody is released from a prison setting, jail setting, it can be related to a number of things, completion of sentence being one, parole or conditional release just related to kind of general parole rules or rules for changes in sentencing related to good behavior, rehabilitation within the setting, and then also compassionate release, which is related to specific variables about the individual, sometimes age, sometimes related to, serious illness or life-limiting illness, to provide opportunities for someone to be in a community setting and not in a prison setting when they pass away. This has become sort of a bigger factor, as Brink and Wiley point out in their book, after the First Step Act of 2018, which was at the federal government level an acknowledgement of some of the missteps with some of the heavy sentencing guidelines from the 80s and 90s, and trying to make adjustments for folks who've been in the system for a long time on sentences that at this point would not have been as severe. And so part of that program is that the Attorney General is tasked with developing sort of a risk assessment process for deciding who under those guidelines could be released earlier than the original sentencing guidelines suggested. And there are a number of different tools that people use. Those of you who do risk assessment know there's no end to the opportunities to find a different tool that does this, that, or the other thing related to risk assessment. But they did create the prisoner assessment tool targeting estimated risk and needs, or the pattern risk assessment, specific to answering questions related to the First Step Act. And age as a factor is included in that risk assessment with a general score and violence score of 0. So when we're considering sort of risk, age is a protective factor independent of other things. But as we've been talking about, just because you know someone's age doesn't mean you know everything about them. Recidivism data from the Bureau of Justice Statistics from folks who were released from 34 different state prisons in 2012. This data comes from 2012 to 2017. As you'll see, for folks who are 65 and older, the sort of highest proportion of those who did commit additional crimes was within the first year. And then each year after that is proportionally sort of lower and lower as you're looking at older adults. And so when we're thinking about kind of regular considerations around release, just knowing that a person's sort of 65 and over gives some opportunity to make considerations that may not be available for younger adults in terms of risk. However, factors related to the crime, to other sort of adjustment factors, to behavior within the prison system, all of those risk assessment variables are still quite important. But age does become something that that can be used sort of as a protective factor. And that is, I think, acknowledged within the system by this idea of compassionate release, with age being the sort of covering factor. Compassionate release for individuals who are very ill is a different set of considerations, although a similar process. And there are multiple states that include, in addition to or in separate from considerations around health, considerations for compassionate release just related to age. So Families Against Mandatory Minimums is a nonprofit group, and their general counsel has put together a report in 2018 where they looked at all 50 states and the District of Columbia to review their laws, policies, regulations, kind of anything they could get their hand on to try and come up with summary guidelines on what is available for folks related to compassionate release in the states. Because this is UNM, we're highlighting New Mexico. They do have medical and general parole. Their medical parole covers individuals with serious medical conditions. They also have a consideration for terminally ill prisoners who have 6 months or less to live, and then also older adult prisoners, which is defined as 65 or older, although to Dr. Kahn's points earlier in the presentation, that may be missing a chunk of folks who kind of biologically are older than their chronological age would suggest. Only Iowa at the time did not have compassionate release opportunities, but as we'll see, even with laws on the books, regulation on the books, compassionate release is not something that's used very often. So these data are very current from the U.S. Sentencing Commission, covering October 2021 to September of last year. And the green line at the bottom, although the markers aren't there, it rarely hits 100 in terms of the number of compassionate release motions that were actually granted in the federal system throughout that time. And as you see that line, if we're kind of middling it out, it hasn't really moved, even though the population's aging, we're more aware of some of these factors. This isn't really an option that's being used a lot by people, and there are lots of reasons for that. Again, the sort of Families Against Long Sentences group has come up with kind of barriers that they noticed in their review of state policies, including vague eligibility requirements, categorical exclusion, so things including, type of crime, level of violence, things like that, that just would keep someone from being eligible. Missing or contradictory guidance, so someone filling out all the information that they could based on, one set of rules and then realizing that the decision makers were using a different set of rules. It's complex and time consuming, and often, particularly for compassionate release for terminal illness, 6 months is not a lot of time. But as any of you who've worked in the justice system know, justice moves really slowly. And so 6 months may not map on in the way that it would need to for someone who's sort of dealing with an end of life consideration. And then timeframes being unrealistic. Now, if you look at all of those barriers and then think about Dr. Tussey's presentation, if you add dementia or cognitive impairment on top of that, someone trying to navigate this on their own, it's almost impossible. They do recommend some best practices, including involving family, although as we'll talk in some of the barriers, that can be difficult, particularly for folks who've been incarcerated for a very long time, or folks who are older adults whose closest family members may also be older adults and have similar needs. Having clear criteria, reasonable procedures, or representation, not just legal representation, but even case management or social work representation, someone who understands the process, kind of supporting that person going through the process of making a motion to file for compassionate release. Release planning, there is a degree of that depending on what system you're in. You may have wonderful release planning options, but that's just not the case everywhere. A right to reapply if, for instance, someone does have a diagnosis, but the medical documentation wasn't sufficient, hearing that denial and then having the right to get more sufficient documentation and coming back to the group with additional application materials would be helpful. And then tracking and reporting outcomes so that these things can be followed, and that as the older adult population increases, strategies to improve can be put into place. Barriers to reentry are true for everybody who's released from the jail or prison setting, right? There's housing issues, employment and income issues, and healthcare barriers, and these are all kind of, exacerbated a million times for folks who are older adults, particularly for older adults who have chronic health conditions, including dementia or cognitive impairment. The Prison Policy Initiative has put together information about kind of how to focus on specific barriers, including, untreated mental illness and substance use, which are comorbidities within the prison system that we talk about a lot in these talks and in our kind of conversations as forensic psychologists. Restrictions in housing, either specifically and explicitly in certain public housing situations for folks who come out with felony convictions, or landlord discretion, and would someone decide not to rent to someone who's had a prior conviction. Nursing homes and congregate housing facilities sometimes do have restrictions, particularly on individuals who are coming in who have felony convictions for violent crimes or for sex offenses, and wanting to be sure that there are opportunities for people who are older adults who may need those services to be able to utilize those services. Employment becomes a big issue for our older adults leaving the prison system, particularly those who had been incarcerated at a young age, because they do not have a work history. Even if they were working within the prison system, they've not paid into Social Security or Medicare. And so they can have issues with being able to access a social safety net that is available to other people who are similar in age, but who don't have that history of sort of a gap in living in the community and working in the community. There are also healthcare barriers related to the other issues that we've talked about, and also related to chronic health needs and cognitive impairment that we'll touch on in just a minute, focusing on, as Dr. Tussey brought up, social determinants of health. So more and more in the sort of public health and healthcare provision community, we're aware that what someone comes in with in terms of their demographics that are identifiable and categorized in a medical record, like age, sex and gender, ethnicity, or race, problem list or diagnosis list, aren't telling the whole story of why chronic health conditions are as hard to treat in our population as they have been. And social determinants of health are one way to sort of conceptualize the things that are health related, but are not kind of incorporated into our current health system. And if you see these: economic stability, social and community context, neighborhood, healthcare access and quality, all of these things are things that can be difficult for individuals coming out of the carceral system to have access to, and to gain access to, and to be able to kind of overcome those barriers in order to get the health care that they need. And so particularly in states where there hasn't been a Medicaid expansion, there may be blocks from older adults leaving a carceral setting to be able to be eligible for Medicare and Medicaid. And also, as I mentioned, the sort of Social Security issue: if you've not paid into the system, that kind of normal age-related route to Social Security may be too far out of reach, and then it becomes documenting disability in a way that can be difficult for a person who is disabled to document in a way that makes it likely that they would get the services they need. There are reentry programs, but they are very limited. So for individuals within a community who are older adults, so again, that's sort of 65 and up, some aging agencies will include younger age folks with disabilities, or younger ages than 65, but 65 plus really is kind of the rule of thumb for things like retirement, for healthcare, for being considered an older adult. And in a review of 622 area agencies on aging between March and April of 2016, 9% said they had specific programming for folks who are coming out of a jail or prison setting or being released from jail or prison. And 40% of that 9% was on chronic disease self-management. So helping people manage their blood pressure, their diabetes, things like that. Not necessarily some of those other issues that we talked about, like housing and economic stability. And so we've got a lot of work to do. We can be helpful in some of these ways. If we had more time, we'd talk more about opportunities for evaluation and assessment, since that's a lot of what we do. Those include some of the things Dr. Tussey mentioned in terms of guardianship. You know, if somebody is coming out of the prison system with the diagnosis of dementia and doesn't have family support, how do we make sure that there's an opportunity for substitute decision making if they're not able to manage their own funds that are coming in, they aren't able to manage getting into a housing support situation, getting into a nursing home, identifying housing options before release, potentially social worker or case manager assistance with completing benefit applications, again, before a person is released from jail or prison, locating social networks if someone's lost contact with family, connecting with community resources to try and find people who may be kin or old friends or things like that to sort of support when someone's coming out. And then at the sort of broader community level, public-private partnerships between nursing facilities and jails or prisons or hospitals to sort of help with release planning, help with support, help with behavioral plans and things like that. Community partnerships between aging services and mental health services, and then improving access to public benefits at the state level and at the federal level for folks who are sort of coming out of the federal system, and maybe some of those state-based but federally operated organizations. And some of this comes from a project called the Aging Prison Population and Dementia coming out of Duke Law School. And so there are lots of things that we can be thinking about and kind of doing. And I encourage everybody, if this is a population of patients that you're interested in serving, that this is a population very much in need of service. So I thank you for your time, and I think we've got a few minutes for questions. I know we're close to time, but appreciate everybody being on.
Yes, thank you so much, everyone, Dr. Khan, Dr. Tussey, Dr. Arredondo, for that very helpful, thorough overview of, as you referenced, a very large need and demand for services for our increasingly aging population. So thanks so much for all the work that you do here and for sharing all of this information with us. The link for the CEU survey, you can scan the QR code that's on your screen right now. There's also a direct URL in the chat box. Make sure that you have this open before the webinar closes so that you can complete that survey for APA CEU credits in the next day or two. The questions that we have so far seem to focus more on the assessment aspect that was discussed. And of course, anybody that has additional questions, you can feel free to enter those in the Q&A box at any point. Somebody added the context that they had attended a talk last week on performance validity tests with people with measured for low intelligence. They said they had mentioned that some assessments are not specifically normed on that population. So this intersection for older adults who also have a documented low IQ or low cognitive performance, what do you recommend as best practice considerations if considering using a performance validity test?
Sure, I'm happy to answer this, but of course, either of my colleagues that want to jump in as well. So that's absolutely a great question. And Emmy Woods has actually done a lot of great work looking at the population of individuals with intellectual disability and forensic assessment. But in terms of PVT specifically, that's right. There are, caution is necessary when you're evaluating somebody with an intellectual disability and or dementia, particularly as the individual is further along that spectrum. So more impairments, moderate to severe intellectual disability, moderate to severe stages of dementia. That is a subset of the population that sometimes those tests would be inappropriate because you may end up getting invalid results, and it may look as if the person is feigning when they in fact are not, or exaggerating cognitive deficits. So measures that have been validated, again, typically more with uh, individuals with intellectual disability that are mild or earlier stages of dementia would be the TOM, for example. The word memory test, the MSVT, all within Paul Green's work. Those particular items, and again, particularly the TOM, has been validated in those populations. But I would encourage you, because there are so many nuances, and not the least of which is the cultural, linguistic, and other aspects of the individual's background that have to be taken into account when you're considering tests and their norms. So I would consider that with each individual you're evaluating, make sure to choose the measure that is best for them given all of those factors, but also that it really is an integration of all of the data, not just one performance on the TOM, for instance. And so I'm going to be, as I know all of you are as well, we're going to synthesize all the data and we're going to look at their functional behavior as well. How are they performing on the test versus how they're actually functioning in the carceral setting that you know from records, for instance? If possible, to have family members that you can speak to that can attest to their functioning. Now, as Dr. Arredondo pointed out too, this may be difficult, and as individuals age, the people in their lives are typically also aging as well. I've had plenty of evaluations where the collateral interview was somebody that had substantial cognitive impairment of their own, and it really was of no utility. But that integration of all of the data, including the appropriate measures like the TOM, in that population is ideal. I would document that in my report always, though, any of these nuances or considerations for interpretation.
Wonderful. In situations when formal testing cannot be completed, what are some key mental status, behavioral observations, otherwise questions that you would suggest for differentiating between dementia and typical aging when stressed by their legal situation?
That's a great question too. Anybody else can jump in. I'll just say quickly, I think this is why it is so crucial that we are aware about, as Dr. Khan pointed out, what's normal aging or typical aging expectations versus pathological aging. And it is normal, for example, as we all age, to forget where you put your keys or forget where you put your cell phone. That is not problematic in and of itself. To occasionally even forget a word. But when these become pathological or more consistent pattern of such symptoms, that's when it's concerning. And so when testing is not possible, which happens, frequently, then it's important again to look at the functional behavior of that individual as noted in records by other people who are observing the individual, to pay attention to those observations when you're interviewing them. It's not just what they say they can and can't do, but it's what you're observing. Do they remember your name, for instance, after you've interviewed them for a little while, or other information you might have provided to them? So I'll come back to I think it's really about synthesizing the data about their functional behavior as best you can get from the interview and collateral records when testing is not possible. And even when testing is possible, it's really just one piece of the puzzle.
Yeah, and I'll add to that what Dr. Tussey said, the importance of records and kind of the observations over time. Dr. Tussey went over the fluctuating symptoms, and perhaps they can present at different times or differently across days and weeks and months. And so getting a good idea of how they function in their setting over time is really important. And across settings, do they tend to do better in the smaller groups, or do they present similarly, regardless of who they interact with? I've evaluated defendants who have been in the hospital system for multiple years, and they still cannot tell me who the provider is for the last 5 years, and that tells me something. Because I even had one recently that said, I don't have a doctor, and they've been in the hospital for quite a few months now. So I think those are all very telling. And as Dr. Tussey has stressed, kind of integrating that information with what you observed in your interview and or testing if testing is possible.
And I'll just jump in and add super quick. Dr. Ryan Schroeder and Philip Martin, they're neuropsychologists who do a lot of forensic work. They have done some excellent work looking at PVTs in a variety of populations, but in a forensic context, including aging populations. And so they've published on this, and I highly recommend taking a look. They talk about ideal test, different cutoffs to use, etc.
Wonderful. Thank you for that. Uh, some of us do these evaluations outside of the context of the institutions that people might be in, having limited exposure. What are some recommendations in those contexts for differentiating between delirium and dementia if you don't have access to medical data or medical records and you have these kind of time-limited exposure to people?
I think that's a great question, and I think it's one of the things that is always tricky about being that kind of first pass evaluator, especially if it's something like competency to stand trial and you're the first medical professional or healthcare professional who's seeing the person, is really trying to get a sense of timeline potentially from whoever it is that is around them where they are, right? If they're in a jail setting, did this person look like this when they came in? How long have they been there? What kinds of issues are they having? You know, it's unlikely that a delirium would last for months at a time, but if somebody's sort of chronically undernourished, or has, you know, hyponatremia or B12 deficiency or something like that, it's possible that it could. And so sometimes you may be left without enough information to make that call. And at that time would be appropriate, I think, to say, this is what this looks like, but it could also be something more chronic. And so I would recommend, you know, these steps get taken. And then if this person doesn't improve, either a reevaluation or restoration attempts in a different setting.
Wonderful. And as we wrap up here, one final question. Somebody asked about strategies that you would consider most effective in differentiating neurocognitive impairment from cultural or linguistic influences on functioning. I think they mentioned in a competency context, especially if the interpreter's use did not fully clarify apparent confusion or tangentiality.
We always want to be a little bit humble when we're assessing folks for whom we don't have the cultural and linguistic competence to assess them in their preferred language with tests that were created for evaluating cognitive ability in that language from that culture, because that does create a substantial barrier to validly evaluating what is cognitive in nature and what may be just a mismatch between the tests we have available and the person being evaluated. I think, again, to the degree that you can get additional information to contextualize their presentation, it's helpful either talking with family members or community members. If the interpreter is from the same area, speaking a similar dialect, and can speak to whether or not the person is confused or using language in an unusual way for the language that they're using, that can sometimes be helpful. And then also, what does this look like sort of consistently across settings? Is it that it's only when the evaluation is happening? Is it that this is also true when the person's trying to work with their attorney or when they're communicating with people in the hospital or the prison? It's really difficult, especially if you're in a place that's under-resourced and there aren't interpreter services to give you those data, and a person's not really being communicated with effectively in the settings. So it is tricky, but I think having some caution in how firm we are in our diagnoses and using as much information that doesn't rely on tools and relies more on consistency of presentation over time, I think can be helpful.
Yeah. And I'll just add to that very quickly. I think professional humility is so important in so many contexts, especially here in this very complex evaluative situation where you're using interpreters and there are other considerations about the person's health and functioning. And I think it's important to consider when we're doing the evaluation, as Dr. Arredondo said, as well as noting those limitations, as I mentioned earlier, but noting those limitations in your report and being very upfront about that. I know sometimes that can we may hesitate to do that because it may seem as if we're less than doing our job. But in reality, I would argue that that is the best way we can do our job, by maintaining this professional humility and communicating the limitations in the evaluation process that are inherent, whether someone has cognitive deficits or not, but just when you're using an interpreter, even.
Dr. Khan, Dr. Tussey, Dr. Arredondo, thank you so much for this helpful overview, all stages, all the different types of ways that we might be able to help and assist with an increasingly needed service in assisting those aging in the legal system. Thank you so much for staying after to answer these questions. It's been very helpful for many here involved. And that wraps up this week's Law and Mental Health series. As a reminder, next week we have Dr. Tally Armstrong, who will be discussing artificial intelligence use and considerations related to forensic psychology research. We hope to see you then for another great discussion in behavioral health issues in the law. Until next time, take care.
Thank you for having us.
Thank you.
Absolutely. Thank you so much.